Okay, so thank you again, everyone. Let's begin. So hello to everyone tonight. My name is Roshane Francis, and I am the Manager of Research Grants, Impact Communication and Evaluation at Crohn's and Colitis Canada, and I will be the moderator for tonight's event. So before we kick off tonight, let's go over some updates and technical details. So this event is being offered in English and French audio. And if you want to listen in on French, please select the interpretation or globe icon and choose French. And that way you should start hearing everything in French. And furthermore, if you want to see the slides in French, in the top, you should be able to pick, there should be two tabs, one labeled English and Francais. And if you want to see your slides in French, please click Francais. If you're facing any technical problems during the event, try refreshing the website browser or relaunching the Zoom webinar. You can also leave a comment in the Q&A box, and either me or my colleagues will get back to you as soon as possible. The next thing that I wanted to go over was the land acknowledgement. So I'd like to acknowledge the rich history and heritage of Canada's Indigenous people. While we meet today on a virtual platform, we recognize the importance of lands which we call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, Métis, and First Nation people that call this land home. Through this acknowledgement, we express respect for the traditional territories of the Indigenous communities and contribute to the promotion of reconciliation. I'd also like to issue a quick disclaimer. The content in this presentation by Crohn's and Colitis Canada is intended solely for educational purposes. While the information holds general value, it may not be applicable to specific medical situations. Online resources should not be seen as a substitute for the personalized judgment and care provided by a trained healthcare professional. Crohn's and Colitis Canada does not endorse any external product or service mentioned during the webinar. So for those of you joining us for the first time, allow me to share Crohn's and Colitis Canada's commitment with you. Our organization is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, awareness, and advocacy, our organization strives to enhance the lives for everyone affected by these chronic diseases. Next, I thought I would highlight some programs that are available at Crohn's and Colitis Canada. So if you or someone you know is living with Crohn's disease or ulcerative colitis, we invite you to explore our Crohn's and Colitis Connect platform. It is essentially an online community where individuals with lived experience can share, have a safe space to share their experiences, I also wanted to go over some upcoming sessions. So on July 29th, 2025, so this year, there is a Canada-wide peer support event taking place. So you can also visit our website or check out these events with our QR codes. Okay. So today we'll be talking about Canadian drug access and reimbursement, and the subtitle with Navigating our Dual Payer System. So before we begin our session, I wanted to launch a quick poll to evaluate what everyone's general understanding about this topic was. So just give me 2 seconds as I launch the poll. And that should be popping up on your screen right now. And essentially the question is, how would you rate your current knowledge on drug access and reimbursement in IBD in Canada? And I'll give everyone about 30 to 40 seconds to take part in the poll. Okay, we're nearing 40 seconds. So I'm sure everyone, we won't be able to see the average of the results, but it seems like we're around 3 to 5 for as a pre-poll level. So thanks to everyone for answering. I'm going to end the poll, sharing. Okay. Okay. So thank you for taking part in the poll. And now we will proceed to the first portion of our talk. Ooh, sorry, which is a short presentation by our lived experience partner, whose name is Gaishan. So briefly, very briefly, I'll give you a very short introduction and then Gaishan can come on and talk about his experience. But he is a first-gen Sri Lankan Canadian and a second-year medical student. He was diagnosed with IBD in 2021 and faced his own challenges, some of which he will share with us today. He now volunteers with CCC and aspires to become a gastroenterologist, committed to providing compassionate care for those with IBD. He is currently conducting research that applies AI to identify factors associated with early mortality in individuals with IBD, with the goal of improving the quality of care for everyone. And I also wanted to add personally, from our interactions, he is an extremely thoughtful and kind individual. And I'm very grateful on behalf of CCC for him to be able to join us today and share his experience with us. Gaishan, if you can turn on your camera and then come online and share your experience.
Hello, everyone. I just wanted to say thank you so much for the introduction. I really appreciate it and for the opportunity to share my experiences navigating both my diagnosis as well as the process of getting treatment this evening. As mentioned, my name is Gaia Sean. I'm a first-generation Canadian and a medical student at the University of Toronto. And I'd like to think that some of my experiences with IBD and some of the challenges I faced have really motivated me to try to become a gastroenterologist in the future. So um, I think some of the challenges that come with an IBD diagnosis for myself, which was ulcerative colitis, is that it can be really difficult to open up and discuss openly, creating a sense of isolation. I was diagnosed in 2021, around the time I was doing my master's degree in Ottawa, and um, I soon after I was diagnosed was the first time I ended up being hospitalized within 3 weeks after my diagnosis. And during that time period, within a span of 3 years, I was in and out of hospital for about 8 months. And this had a huge social impact. I didn't know what the next day would look like, if I was going to be okay, or if I would end up needing to be rushed to the ER. I distanced myself from social outings, and I think these are all experiences that others with ulcerative colitis also deal with, feeling like that. Unfortunately, though, there were very loving individuals in my community, such as my friends, my partner, my parents. Um, it it still is a very different circumstance living with a condition that unfortunately if you yourself aren't living with it, it can be really difficult to understand. And so there was a great sense of isolation that I unfortunately did face. And as I mentioned, social outings were difficult too because when you need to go, you need to go. And if I'm in an unfamiliar place and I'm not sure where the washroom is, I would feel very anxious in that situation. Um, and overall, I just felt betrayed by my own body, despite the sort of support that I had around me. So when I first started with my diagnosis, I was prescribed 5-acetylcholine, or also known as mesalamine or Pentasa. And this is what's considered first-line medication, and I used that for the first 3 years of my ulcerative colitis diagnosis. I will say this was around the time that I had the most severe symptoms, and I was very much afraid of figuring out what else was out there in terms of medications that were available because unfortunately, other medications are significantly more expensive. Um, and Eventually, I after the last time I was hospitalized in that 3 year period, I just had to sit down with my gastroenterologist and have a frank conversation about it, and we ended up he really suggested that we should consider switching to a biologic. And One of the major concerns I had about switching to a biologic was that they're significantly more expensive and there's no way I could pay for out of pocket. The one that he suggested was a medication called Entyvio. And each infusion is around $4,000. And I would need an infusion every 8 weeks, which is just absolutely not feasible, especially since I am just a student at that time and even now. Um, Yet he said these few words that still stuck with me to this day, and that was that n not a single one of his patients have been barred from access to the medication that they need just because of the fact that they're not able to afford it. And although I was worried about about having to pay out of pocket, um, that statement rung true for the first year of receiving this medication. I was given Entyvio on a compassionate care basis through a patient partner program. And I was connected with a case manager who helped manage the ensuring that I'm able to have access to compassionate care. And from the first few infusions of Entyvio, I very quickly went back into remission. Like it was life-changing. I was able to go back to feeling normal, not having to worry about, if I need to rush to the washroom when I'm somewhere unfamiliar. It felt like I was back to a point in life where I didn't have to worry every day about the diagnosis of ulcerative colitis. Um, and just knowing how much of a benefit that this gastroenterologist had for me, and was a big reason why I see myself wanting to pursue gastroenterology now. However, things took a bit of a turn when, unfortunately, the company that dispenses this medication wanted to transfer their patients towards a publicly funded program. Um, in Ontario, the publicly funded program that's available is known as Trillium. This is essentially a public drug benefit program, and it's offered to individuals who cannot pay for medication if it is 2% above the annual household income, which was very much the case for me, with it being $4,000 every 8 weeks. And so at the time, I was under the impression that I would get some amount of help to be able to navigate the Trillium application. However, unfortunately, communication fell apart, and I ended up having to work on the Trillium application myself almost entirely. Yet, despite being now a medical student as well as having a significant English proficiency, I found the application to be incredibly difficult to navigate. I eventually got through it. I had, and I was able to submit my application. And I started receiving receipts from Trillium saying that my medication is now covered. So great. I'm still going to the pharmacy, getting the infusions, and after the infusion's done, a few weeks later, I would get a receipt saying, okay, your infusion was covered. Yet I went, so this went on for a couple months. And then one time I went to to get my regularly scheduled infusion, and they I was ready to get the infusion, and then the nurse told me, hey, your infusion wasn't given. There is actually an issue with your insurance. And so I called up both the program that dispenses the medication, as well as Trillium, and it turns out that because to be part of Trillium, you need to have how it works is that, just to give a bit of a brief idea of it, Trillium first wants to take any payment that's available from private insurance. And then once that deductible is paid up, then Trillium is able to cover for any extra cost that's involved. For myself, I am currently under insurance as a undergraduate student. And that insurance was willing to actually cover the cost of my medication up to a certain deductible. Yet because the deductible is so small, within a few infusions, it got completely used up. And so Trillium was unable to basically process the payment for the medication through my insurance plan. And and they had no communication on what was going on that end. So unfortunately, it was up to me to then try to coordinate between Trillium, um, between the insurance that was provided my group insurance as an undergraduate student, and also communicate to the pharmacy on the status of what's happening between the insurance company and Trillium. So it was a incredibly anxiety-inducing time period because while all this was going on, I had not received my medication. In total, it took about 2 months for me to be able to get this situation resolved because of how much back and forth there was and how much it involved me to figure this out while all the while not really knowing how best to navigate the system. And it caused a great deal of anxiety because I actually missed a medication dosage. I started having symptoms coming back, and I was fortunate that the pharmacy was willing to give a bridging dosage during that time. Once I mentioned that my symptoms starting to come back, but I was very aware that if I wasn't able to get this solved, that I would continue to have issues being able to access the medication that had completely changed my life at that point. Um, Fortunately, I was able to eventually figure out what had to be submitted, got the forms in, and Trillium was eventually able to accept the information from the insurance company, and I was continued to be covered appropriately for this medication. I think some of the things that I learned through this process were um, actually, quite a few things. I felt a lot of blame for myself for not really knowing the system that well and for leading to a situation that maybe I should have been more aware of, whether it was, knowing that the private insurance deductible would be used up quickly, being able to navigate the system better. But really, I think what it comes down to is that unfortunately there are a lot of barriers in this system, and it really should not have been the blame. I really should not have put so much blame on myself for not being able to navigate the system as well as I did. And it was isolating. A diagnosis of IBD is already isolating. Systemic variants such as this definitely added significant more stress to a condition that already put so much uncertainty and anxiety on me. Um, I I also, through this time period, heavily relied on my friends and family. My partner, who had also seen me through the times I've been hospitalized. These are all individuals that I tried to lean to as much as I could, despite, although they may not have necessarily been able to help me figure out how best to navigate the situation of getting insurance coverage, or sorry, getting Trillium to continue to cover the medication. They were individuals that I reached out to because of the anxiety that I was dealing with. And the other thing that I realize now actually is that thanks to the knowledge that I was able to gain about this process and some of the pitfalls that can happen, I was actually able to help a friend who was transitioned to the same medication recently to help them have their Trillium application filled out. And my dad is actually now, for a separate condition, we're looking into getting him Trillium payments as well. And I'm so happy that I'm able to now, with the knowledge that I have, help him get his application approved and move forward with that. And honestly, looking forward, I've definitely learned several important things, including the fact that in medical school, we learn about so many of these programs that are available, but accessing them is a whole other barrier. As I mentioned, despite the level of medical literacy that I might know as a medical student, and the fact that I feel like I'm fairly proficient in English, I can't imagine how hard it might be to navigate the system as an individual who may have difficulty with either English or maybe even more unfamiliar with the medical system than I am. Although I will say, in closing, that I'm incredibly grateful that programs like Trillium does exist. Even though access may be a significant barrier, there would be no way that I can afford this medication on my own without the fact that um, this sort of program is available. Um, and I also really think that there should be the opportunity to be able to better coordinate between, the entities that I had to deal with to get my medication covered. And although I had to navigate it personally, I'm not sure if that might be the case for everyone out there who maybe have to. And I just hope that having had this opportunity to share some of my experiences today may shed some of the lights onto the benefits some of these programs that are such as Trillium have available. Um, and but at the same time, just to also be aware that at least for myself, I unfortunately had to face also significant barriers ensuring that I have continued access to the medication that I so desperately need to maintain some level of normalcy in my life. Thank you so much for listening to me talk. I really appreciate your time today.
Awesome. Thank you so much, guys, Sean. And again, I really want to thank you for being so open with us and for sharing your experience. And your story really highlights the gaps that individuals with lived experience may face on a system and administrative level. So, and how important it is as for us to have awareness of it and then further work on reducing those gaps for individuals such as yourself. Again, thank you so much. I really appreciate you sharing your experience with us today. Now we will move on to the second portion of our talk, which is given by Laura. So I'll also introduce her quickly. So Laura is a senior consultant at PDCI, and she is a member of the commercialization and launch team, where she advises pharmaceutical companies on market access and reimbursement strategies. The next individual we have is Paul. So Paul Hendricks, he is an associate director with the same PDCI market access. He has a deep understanding of how public provincial drug programs work with private insurance. Paul was also recently a part of a study to investigate how insurers can pool their resources for greater collective impact. So I really want to thank both of them for being here today, and Laura will be leading the talk. So before, again, thank you to both of you for being here, and please take it away, Laura.
Great, thank you so much. So, hi everyone, I'm excited to be here tonight to speak about Canadian drug access and reimbursement. And as we just heard from Gayshawn, there are a lot of barriers that patients could face throughout their treatment journey, especially a patient with IBD, as they look to navigate diagnosis and treatment and maintain that ongoing treatment. So tonight I'm hoping to provide some insight into the overall market access and reimbursement system within Canada, provide insights into some of the differences that you may see or experience depending on the type of drug coverage you have, where you're located, and all of those nuances. And hopefully through all of this, provide some tips for patients as they look to navigate the system here in Canada. So I wanted to start out with a fundamental piece of this is, what is drug access and reimbursement, and what does that actually mean? So when we're referring to drug access and reimbursement, this is also referred to as market access, and it's essentially the practice of ensuring that patients have the ability to obtain the medication they need when they need it at a price they can afford. So these are all the practices that pharmaceutical manufacturers and stakeholders throughout the industry take to ensure those conditions are met. So throughout tonight and throughout the treatment journey for patients, there may be many questions that come up and that through various stages related to reimbursements that we hope to be able to address tonight and provide some insight to you. So aspects like, why is a specific treatment selected, and does reimbursement play a role in these decisions? Will my drug coverage cover this drug? Or why isn't this drug available, and why isn't it covered? As a patient, am I going to face any out-of-pocket costs? And if so, can I afford them? Is there any documentation that's needed to help support my access to this drug? And if so, what does that look like? And how do I navigate that process? Things like, I've lost my job, and with that, I've lost my group benefit package. So what does that mean for drug coverage? Where can I turn? And then I've been enrolled in a patient support program. What does that mean for me? And what can they support me in doing? So addressing these questions, it often feels like there should be a simple answer. And as we heard from Geishan earlier, it's not always simple, unfortunately. When it comes to navigating access and reimbursement in Canada, it is a complex system and it's very individualistic, depending on many circumstances that a patient may be in. So for that reason, there isn't often a simple solution, but there are solutions there for patients. There are support systems that exist and are there to help patients get access to the right medicines at the right time in their treatment journey for the right price. So over the next 40 minutes or so, I hope to, provide you an understanding of these processes throughout the system, some of the differences you may encounter as a patient, and then provide those tips to help you navigate these complex systems. So we can move to the next slide, please. So starting with a little bit of a foundation around, the funding system here in Canada. So where does the funding for drugs come from in Canada? In Canada, we have what is commonly referred to as a dual payer system because there's both public sources of drug funding and private sources of drug funding. So for public payers, those are our government-sponsored plans that are administered by the provincial, territorial, and federal governments. And each of the provinces, territories, or federal plans are responsible for administrating their own, which means that there are 13 independent systems, each with unique policies and criteria associated with them. So for that, it's navigating that public system means there's those 13 independent systems, which each function a little differently. Then there's also our private payers. So these are those group benefit plans that are typically or most commonly provided through an employer as a tax deductible health benefit with the goal of attracting and retaining top talent. But private drug insurance can also be obtained through other groups such as unions or associations or even self-purchase. And over 60% of Canadians have private coverage. And between both the public and private payers, all Canadians have access to some form of drug coverage. But the reliance on the public and private system will vary for a patient. And what that experience looks like depends on a lot of criteria for these patients. And one of the main things can be related to age. I just want to speak a little bit to the figure on the slide here, where it's looking at the primary payer. So this is, that first paying drug plan, so that primary form of insurance for a patient, and how we see trends across the country and that reliance on the public versus the private sources of funding may change with time. So there's three kind of main age groups that need to be considered here: 0 to 24, so those are our youth. The working age population, so that 25 to 64 age band, and then the senior population over 65. So if we look at this graph, there's prominent section in the middle and left, so that 64 years and younger, that blue section, and that's representing private plans. So these are the lives of Canadians that rely on private insurance as their primary source of drug coverage. And we can see this significantly drops off as we move to the right of the slide at 65 years and older, because this is where these senior plans provided by the public payers for patients that are 65 and older will kick in, and we see that reliance on the public system flip at that age. So it's not uncommon, and it's actually expected that throughout their lifetime, patients will rely on both the public and private payers throughout various stages of their treatment journey. I'd also like to call attention to, on the 0 to 24 age, there's that lighter blue section of 2.2 million lives. And this is our public youth, and that's specifically related to that OHIP Plus plan that provides public coverage for people in Ontario under the age of 24 and under. So that's a portion of the population there that is publicly reimbursed. as the primary form of drug coverage. So for a patient in Ontario, it's very plausible that they may, have a private insurance when they're quite young, as a dependent to their parents' plan that they get through their employer. And then maybe they age out of their parents' plan, but are still under 24. So then they flip over to the public system, have coverage through OHIP Plus. And then they get their own benefits package through an employer and change back to the private system. And then they retire and go back to the public system again over the age of 65. So there's a large level of reliance on both systems throughout a patient's life. So it's important to understand both and how they work together. So I mentioned earlier as well that, between the public and private system, all Canadians have access to some form of drug coverage, but that would be neglecting that orange portion of the graph. And that is classified here, that public cash market. And that's considered our underinsured population in Canada. And it's roughly 11% of the Canadian population. And these patients have access to drug coverage, but it does not sufficiently meet their needs. It's where there's things like enrollment. So we heard about the challenges in navigating enrollment with Trillium, where there's barriers to accessing that. It's not meeting their needs, or there's very high income-based deductibles that need to be met before this drug coverage would kick in and be covered. And these can be, significant barriers for patients. So there is still that 11% of the population that's considered underinsured. So what does this mean? For patients, in the end, it's really that, there are options out there throughout your life cycle. It's not uncommon that you'll flip back and forth between public and private, and navigating that can be challenging, but there are solutions out there for you. And that dependence on the different systems will change throughout your life. Next slide, please. So another thing that often comes up is barriers for access, and it's a well-acknowledged challenge in the industry, is time to access. So a patient may hear of a new drug being approved by Health Canada and are very excited about it, but are not able to access it through their drug plan. The drug plan isn't covering it yet, or it takes a long time for patients to potentially be able to access these medicines. And, what is the process that's happening, and why is it taking so long? So to navigate that process from getting Health Canada approval of a new drug to getting access across the country by payers, it's not uncommon that it can take 2 years or longer for that to happen, which is very unfortunate. And it's because there are a lot of things that need to happen in that access and reimbursement process, each of which takes time and is important steps in the process to ensure that the right patients are accessing that right medicine at the right time in their treatment journey, and that an acceptable price can be determined. So, I'm very frustrated typically on a day-to-day in the work that I do on the increasing time to access that we're seeing. And the advice that I have, unfortunately, is to be patient, but if there are true solutions out there, there are ways to navigate them too. So if there's, really exciting medicines that come out that your drug plan, isn't offering, those are conversations to have with your treating clinicians, as there may be avenues to access things earlier. But generally speaking, patients do need to wait for that drug to be listed by their drug plan. And it's because they are navigating these reimbursement and access processes in order to gain those listings, which is very frustrating for patients. So generally speaking, when it comes to the timelines, again, we have the public and the private payers. And of course, because nothing can be simple in access and reimbursement, these two paying sources have the different processes that they have to navigate. There's different systems for each of them. Generally speaking, private payers will list more drugs than the public payers, and they will do so more quickly than the public payers. But there is increasing time to listing with the private payers as well, as drugs are getting more specialized or more expensive. They're being more thorough in these reviews that they're doing. So let's focus a little deeper on the public payers for a minute. So within the public payers, once a drug receives Health Canada approval and is considered safe for sale and approved for sale in Canada, that is really where the what is referred to as the market access activity really kicks off with the health technology assessment, the health technology HTA review, and this is done by two bodies in Canada. We have INES in Quebec and then the Canada Drug Agency in the rest of Canada. And this process takes about 6 months, and they are evaluating the clinical and cost effectiveness of medicine compared to what the drug plans are already paying for. Then and for the public system, you have to have a positive recommendation from the HTA review that the drug should be listed by the drug plans in order to move to the next step. So which the next step is then national level price negotiations, which happen through the Pan-Canadian Pharmaceutical Alliance, or the PCPA. So this is at a national level where price negotiations are happening between the provinces and territories and the pharmaceutical manufacturer to establish that right price for the treatment. And this process takes a significant amount of time. You'll often be waiting 6 months to even initiate negotiations, and then those can take a year and sometimes even longer. Then once those national negotiations are completed, the manufacturer then has to finalize all the agreements with the individual provinces, territories. And this is where we really see the variation in provinces be introduced. This is where things like reimbursement criteria, which is the conditions a patient must meet in order to receive funding for the drug. We commonly see things like having to have failed on a first-line therapy that's typically lower cost before the drug plan will pay for a second-line therapy that's higher cost, or specific diagnostic criteria or lab results. That's where those things will get introduced. But it's important to note also that provinces and territories aren't required to list all the drugs. It's an individual provincial decision. So it's not uncommon that we see a province decide that, no, we don't need to list this. And a province may choose not to. And that just means patients located in that province, it's not a part of the formulary there, unfortunately. So that's really at that end step where we really see the variations come out across access and reimbursement for patients in the public system. And all of this easily takes 2 years from the time it's approved by Health Canada. So with the private payers, as mentioned, it's typically a little quicker. So usually there's listing about a year it takes in the most complex plans. So there's kind of 2 different plans within the private payers, largely speaking. Open plans, which are those that really cover anything and don't have any conditions associated with it. And listing will be very quick there, usually within, a couple of months. But then it's becoming more and more common as medicines are getting more expensive and more specialized for the private payers to be introducing reviews and negotiations that are very closely mimicking what's being done in the public system. So this, again, takes time, luckily not quite as much time as the public system, but easily 6 to 12 months in some of these plans in order for a drug to be listed. And in that case, you wouldn't see a product become available for closer to a year. So unfortunately, it is a very complex process that involves a number of stakeholders, and the decisions that these stakeholders are making are not necessarily uniform, and they're not sequential. So it can be quite challenging to navigate all these pieces moving along, and very frustrating for patients to understand why some of the decisions are being made and where things around the reimbursement of a drug are introduced. So next slide, please. So why some of these decisions are being made and some of the things that the payers are considering in these reviews that are the foundation to those listing decisions. So whether or not the payer will actually cover the drug at all, and if any reimbursement criteria will be needed in order to ensure the right patients are accessing this drug. So in this, they'll consider, a number of factors, but some of the kind of key ones are around that comparative clinical benefit. And this is where they look at the clinical trials, evaluate that safety and efficacy of a drug, and the therapeutic benefit that it provides relative to what is currently available on the market. And they'll also evaluate the unmet need and this new drug's ability to meet those unmet needs. So thinking about rarity of the condition, the total population that this drug would address, and then absence of alternatives, or is the current standard of care just symptom management, or is it disease modifying? That's where those considerations are made. And they also consider the economic factors, so the cost of the drug as well as the cost effectiveness relative to what's currently available. And much of this is all relative to what patients currently have access to or what the drug plans are currently paying for. There's also the patient value. So what value is this providing to patients? And this is where the patient voice and the clinician's voice is really strongly valued to give insight into the burdens that patients and their caregivers are facing currently in their treatment journey, the unmet need in that patient population, and the known advantages or disadvantages of existing treatments, and how this new treatment could address those, as well as those expectations of patients, so what they're expecting of their treatments to be able to do, and the ability for a new medicine to meet those expectations. And then finally, a key factor is around affordability, so economic and organizational feasibility. Are there any, organizational aspects or societal impacts that need to be considered when introducing a new medicine? Are there systemic issues? We see this a lot with diagnostics. So it's coming up a lot around patients needing an MRI before or to monitor their treatment while taking a very highly specialized medicine. Of course, in Canada, access to MRIs is incredibly limited. So that's where those factors will be introduced. So can this health system effectively implement this drug to treat patients and make sure it's getting to those right patients? So these are all those factors that the payers will consider and, really build into that decision of whether or not they're going to list the drug at all, and whether or not they need to associate any criteria to it to ensure the right patients are accessing that right medicine. So all of this is highly complex, and of course it takes time, unfortunately, and that's why we see that 2 years or even longer sometimes before the drug plans are making those decisions and listing these drugs for patients to access. Next slide, please. All right, so those slides really was intended to set that foundation so that as a patient, you can understand that the system of access and reimbursement in Canada at a very high level, those two key players of the private payers and the public payers, kind of how as a patient you may, change your reliance on each of those systems throughout your lifetime, and then what that time and the process to access and reimbursement looks like, and what are those considerations that are being made just at a general level for the payers in making these listing decisions. So I'm going to spend the rest of the time today speaking more specifically around IBD patients and some of the, variations you may experience depending on which source of drug coverage you have, so public versus private, and hopefully through that provide some tips in navigating it. So as we know, in Canada, IBD treatments include a range of therapies, and the selection of these and the design of these are tailored to disease severity and patient response. And there's those three main buckets of conventional therapies. So these are typically more of those first-line therapies, and then advanced and higher cost therapies like biologics and biosimilars, as well as the advanced small molecule therapies. So patients can experience challenging in navigating access and reimbursement with any treatment, but they most commonly arise or have the higher chance of arising and really impacting patient experience with more advanced and higher cost therapies like the biologics, biosimilars, and advanced small molecule therapies. So those are what I'm really going to focus in on in the context of the rest of the discussion today. Next slide, please. All right, so let's dig a little deeper into public payers here. And so for a patient that has public reimbursement, so they'd be relying on a government-sponsored plan, something like Trillium, as mentioned earlier, for the primary source of drug coverage for them. And because the public plans are administered by the provinces and territories, this means that depending on where a patient is located, so which province or territory they live in, will impact their access and reimbursement experience because there are differences in how these plans operate and what drugs they provide on their formularies, which are the list of drugs that these plans cover. So each of the provinces and territories are administering their own plans, and they have often multiple sub-programs that will target different patient populations. There are nuances in the eligibility for each of these plans, and that those are the conditions patients must meet in order to qualify for coverage through one of these public plans. But generally speaking, across the country, the public programs will cover patient populations of seniors that are 65 years and older, low-income individuals and families, or individuals that have high-cost medicines relative to, household incomes, children and youth, disease-specific programs, catastrophic drug coverage for those very high-cost medicines, and then any special populations. There's some programs that exist for those. But again, the eligibility, so the specifics around, being eligible for a certain program and what that might look like for an individual is highly dependent on where they are located across the country. So then once we get through, what it actually means, the conditions to be eligible for that plan, there's also a number of other ways that these plans will differ from each other. So for example, a seniors plan, 65 years and older is kind of that general threshold use. So the patient eligibility is pretty uniform across the country for the seniors plan, but that doesn't mean that a senior in BC will have the same experience or have the same access and reimbursement as a senior in Ontario. And these differences can be introduced in a number of ways. The first of which, of course, is listing status. So whether or not the drug plan and its formulary even covers the drug. Did they choose to list this drug and make it available to patients? And then are there any reimbursement criteria associated with it? So do patients have to meet any conditions in order for this drug to be covered for them? Are there any co-payments? So co-payments are where a patient is responsible for paying a portion of the prescription cost. So for example, if there's $100 prescription cost, the drug plan may pay $80 of it, and then the patient would be responsible for $20 of it. That's a co-payment. And then deductible requirements. So a deductible requirement is where there's a certain threshold that a patient is responsible for covering the whole prescription costs up to that threshold. So if the deductible is $1,000, patients would pay the full cost of their prescriptions until they hit that $1,000 mark, and then their drug plan would kick in, and then they'd have coverage there. There's also coordination that happens between public and private programs. Gaishan spoke about this before, about how he had, private reimbursement through his school that went to a certain limit, and then they were able to access, Trillium would then cover thereafter. That's what's referred to as coordination of benefits, and the ability to coordinate between more than one source of benefits. Of course, I spoke to program eligibility a little earlier, but then there's also provincial policies that will vary across. A great example of this for IBD is biosimilar switch policies. So this is where the originator biologics, so something like Remicade, went off patent. So it was no longer patented, and biosimilars entered the market. And biosimilars are lower costs compared to the originator drug. And provinces started to introduce switch policies where they required patients to use the biosimilars instead of the originator. BC was the first province to do this in 2019, and only at the end of 2024 had all provinces across Canada implemented some form of biosimilar switch policy. And so this means that for a patient in BC, they may have had to switch from the originator drug, so the Remicade, to one of the biosimilars 5 years earlier than a patient located in Ontario, just because of the timing and the rollout of these provincial policies across the country. So it's there's a large level of variation that can be introduced that can really impact patient experience, patient access, and their reimbursement. And it's highly variable depending on where they're located and the individual circumstances of that patient. So if we go to the next slide, we'll look at how this happens a little more closely for some of those advanced therapies for IBD. So when we look specifically at the biologic and biosimilar therapies, as well as the advanced small molecule therapies for IBD, and consider them, their use and treatment and reimbursement in IBD, so Crohn's and ulcerative colitis specifically, we see on this chart great variation in what that status looks like. So the green boxes indicate where the drug is listed as an open benefit. So patients have access to it, and there's no conditions that they have to meet in order to receive access to it. The red boxes are where it's not a benefit. So the drug plan does not list it for Crohn's disease or ulcerative colitis. And then the yellow boxes are where there are special authorization and reimbursement criteria in place that limits the patient population because patients have to meet certain criteria in order to receive funding. It's important to note that although it may look somewhat uniform in a way with so much yellow, that criteria that patients have to meet will often be slightly different depending on the province, depending on the plan. So just because there's special authorization or there's criteria for a patient on like Rinvoq, for example, the second line from the bottom, every province except Quebec has listed this with special authorization criteria. But it's very plausible and likely that the reimbursement criteria that a patient needs to meet in order to get funding will be different between British Columbia and Alberta. So there's a lot of nuance there. And so navigating and understanding that individual experience can be challenging, but there are resources available to support patients in navigating this, especially if you can plan early and navigate and have open dialogue with your care providers. Next slide, please. So with that is the public system. And, when we see in public reimbursement, a key thing that impacts the experience in patient and reimbursement, in patient access and reimbursement, is their location. So what province are they located in? But then there's also the private payers. And unfortunately, patients also experience variation in access and reimbursement with the private payers because there are over 80,000 unique drug plans, private drug plans operating throughout Canada, and these can differ at the plan level. So as a reminder, private plans, private payers are those often employee-sponsored drug plans, so where your employer offers you a drug plan. So when we're thinking about it at that level of variation, it means that employer to employer, we can see variations in what that drug plan is, even if it's covered by the same insurer. So, everyone, that yellow and blue drug card that you might have, your reimbursement and access may differ from someone else depending on the plan design of it. And that's because when designing their drug plans, there's several elements that can be implemented that will impact access for patient. And it's really important to understand this because we're seeing a lot of impact on patients, especially those on higher cost medicines, where there wasn't awareness to where some limitations may introduce. So some of these things some of the elements of plan design that can impact a patient's access and reimbursement are, first of all, whether or not their plan is open or it's a managed plan. So an open plan, I spoke to earlier about how you get quicker access to drugs, and there's typically not reimbursement criteria associated with them. But unfortunately, the industry is shifting more towards managed plan design. And this is where drugs are undergoing a review. There's typically longer time for patients to access these drugs. And then there would typically be, more constraints, stuff like reimbursement criteria introduced to help ensure the right patients are accessing these medicines. A form of managed plan is tiered reimbursement. And this can be challenging and often deceiving a little bit because it's not uncommon that you hear, oh, our drug plan covers everything. All drugs are covered. And that may be true, but they might not all be covered in the same way. In a tiered reimbursement plan, there could be, 5 drugs to treat a condition, and 3 of them have been selected for 100% coverage, but 2 of them are, in that evaluation considered, didn't score as high potentially based on those factors of consideration. So they're only 50% covered. So a patient would have to be responsible for covering 50% of that prescription cost. So that's what a tiered reimbursement plan is, where there's coverage for all drugs, but it's not covered in the same way for all of them. Again, co-payments, where patients are responsible for a portion of the prescription cost. Generally speaking, the normal copay we see in the industry is 20% of the prescription. So that's where patients will be responsible for paying 20% of the prescription cost. But it does vary. There's differences there, and it is not uniform. A lot of the private payers, and almost all of them now, have started to implement policies like generic and biosimilar policies, where the lowest cost alternatives, so the lower cost generic drugs or biosimilar drugs, are what is covered, and patients would be responsible for paying the difference if they need to only use the brand name. And then finally, there's a concept of annual and lifetime caps. And this is where an annual cap, so each year, let's say your drug plan says, okay, we'll cover all drugs, 100% of the prescription costs, up to a maximum of $10,000. And as Gaishan spoke to earlier, when you are getting treated with a drug that is $4,000 every 8 weeks, hitting $10,000 annually will likely occur. So this is a reality unfortunately, for IBD patients, and knowing how to navigate and coordinating with other coverage available to help fill those gaps. But then there's also the lifetime caps, where it may be that patients over their lifetime will cover all drugs up to a maximum of $500,000. So, for some employees of that organization, or the majority, maybe this is sufficient, but when you're using higher cost medicines, this is something to be aware of and to consider if the drug plan is meeting your needs. There's also variations in private plans, again, on what prior authorization and reimbursement criteria is associated with getting funding for a drug that patients must navigate. And then even as a patient with private reimbursement, private drug coverage, the policies that the public system implements will often impact the actions and trends that we see within the private payers. So we've seen a lot of the private plans implement biosimilar switch policies following suit after the public programs implemented them. And then also things like pharmacare. Of course, IBD is not one of the indications included in pharmacare at this time. But if it ever were, there's considerations that patients need to make on how potential administrative burden may be introduced because of administrative shifts that happen and requirements that your private plan may introduce in order for you to continue to receive funding for your drug, depending on how the system evolves. So it seems very complicated. It's like, how do I keep track of all of this and what do I do? So if you are a patient with private reimbursements, the easiest way to get access to all of this information is through your benefits booklet. So this information needs to be provided to you through that benefits booklet and should outline all of these policies. So being able to view that and consider whether or not the plan is meeting your needs, or know early on if there's an annual cap, for example, that you're going to run into. You only have $10,000 worth of coverage, and then you're going to need to coordinate with a public program like Trillium, planning for that based on your current treatment, what medicines you're currently taking, and coordinating with your care teams to help support that journey. It's also important because this variation happens at the plan level. So for patients with private coverage, if you're looking to change jobs, you will likely experience a change in access and reimbursement, unfortunately. And this can be really challenging for patients to navigate because you don't want to disclose your medical information during an interview process or while you're considering taking a new opportunity. And as a result, patients with chronic conditions or higher cost medicines, they may feel forced to limit their choice of employers or stay in a certain job because it provides drug benefits that meets their needs. And that's very unfortunate. And the last thing we'd want to see is someone take a new job opportunity only to find out that the drug plan this new company offers no longer meets their needs. So if you're navigating that, an approach that will avoid having to disclose medical information about yourself to potential employers is to ask for that benefits booklet. Ask for the information so that you can make that evaluation and ensure that what's being offered will meet your needs. All right, so with that, if we move to the next slide. So that may seem very doom and gloom. It's highly complex. It's highly individualistic. So for a patient, their access and reimbursement and the challenges that they may encounter throughout their treatment will depend on a number of things, whether or not they're covered by private insurance, public insurance, or even both at times, if there's that coordination of coverage happening, where they're located in the country. And, what circumstances for that patient exist. And because of this, this recognized challenge that patients are facing, there are supports that exist. So these are our patient support programs, which are customized solutions that help to support the unique needs of patients. And they are offered by manufacturers. So they're drug specific and designed to address the unique needs that a patient on that drug may encounter throughout their journey. And the patient support programs are really highly trained individuals that have great experience supporting patients in navigating their treatment journey, including that access and reimbursement piece, and should be considered a key piece of your care team and kind of that point person potentially for you to navigate access and reimbursement through, because really what they're there to help support you with is initiating treatment and keeping you on that treatment. And part of that is making sure you can access this treatment in a way that won't be prohibitory in cost. So there's lots of support that they can provide, even things like, unfortunately, listening to Gayashan's story, there should have been more support through the patient support program there to help with that coordination between the private drug plan and Trillium. And patient support programs are typically designed to help support that. So it's unfortunate to hear that experience. But these really should be viewed as key resources that can help you. And it's also important to note that because they are drug specific, the teams in a patient support program may have also encountered other patients that have had similar experiences and therefore have experience in helping to navigate that specific solution, which is great. But it's important to note that because they are drug specific, the onboarding process for each program can seem daunting for patients, especially if they've been treated with other advanced therapies that have patient support programs, because when you first initiate, you will be asked a slew of questions, and you may feel like, oh, I answered these before. Why do you need to know this information? But it's important to share that with the patient support program so they can help you in the best way possible to navigate these challenges. They need to understand, other treatments that you've been on before, because there may be reimbursement criteria associated with your coverage, and they want to check that you qualify for it. They may ask you questions like, what is your household income? Because there may be the option to look to alternate forms of reimbursement, something like Trillium, that has income-based deductibles, and exploring those avenues. And many patient support programs, as Gayashan mentioned earlier with NTVO, may be able to also provide financial support or compassionate goods to ensure patients are able to continue accessing medicines they need at the right time in their treatment journey. So really, as complicated as access and reimbursement is across Canada, know that there's support there for you, and really consider patient support programs that exist as a key part of your care team and a key resource that you can turn to help support you in accessing medicines and maintaining the treatments that you're on. So next slide, please. So with that, I hope that today I've been able to provide you a background of what access and reimbursement looks like in Canada and those challenges that could introduce, so that you as a patient, depending on your individual experience, so where you are and the conditions and criteria that you meet and what source of funding you have, can better be aware to help you in navigating those barriers and challenges that may arise throughout your treatment journey, and knowing that there's solutions out there for you and there's support out there for you so that you have access to these medicines that are so pivotal in your treatment. Thank you so much. Then pass back.
Perfect. Thank you. Thank you so much, Laura, for sharing all that information. And it's really, I thank you. I think for me personally, the background on the public and the private payer system was extremely insightful just to get an understanding of, how it's set up in Canada. And thank you for also providing those tips, like look into the booklet, before you take a new job, or, reach out to your patient, the PSPs to get if you need information. And as always, there's also Crohn's and Colitis Canada to help patients out throughout that journey. So we really hope today's talk, and again, thank you, Laura, for helping us learn more and navigate the more market access, drug reimbursement aspect of the journey. So before we move on into our Q&A section, I would like to launch the post poll now that we've wrapped up the speaker portion of our talk. So let me go back, and that should now show up on your screen. And the question is, after the seminar, how would you rate your current knowledge on drug access and reimbursement in IBD in Canada? So I'll give everyone a few seconds to answer. It definitely has gone up, Laura, so.
Glad to hear.
Okay, I'll give everyone a little bit more time. Okay, about 40 seconds. I'll end the poll and I'll share the results. And oh yeah, so essentially it was around 3 to 5 when we started. And now I would say it's between 7 and 9. So that's really great to see, and for us to have an idea of how helpful and translatable, accessible the content was. So thank you so much, Laura. And thanks for everyone for taking part in the poll. So now we'll move on to the Q&A portion of our webinar today. So if you have a question, I see some questions coming in, so everyone's taking part. So please put it in the Q&A box found in your Zoom bar. And I also want to highlight that we cannot answer questions about specific medical situations. And I'll also leave it up to Laura, based on your discretion, if you're comfortable answering something. But yeah, so please keep that in mind. Okay, so let's go through the questions. The first one was, am I able to receive Remicade infusions in different provinces if I will be traveling across Canada for a few months? So this was a question that actually we got multiples of. I just picked one of them, but traveling across, between provinces and coverage was a big question.
Yeah, absolutely. And this isn't specific to Remicade. This would be, for any infused medicine or really any treatment. So long story short, it's possible, but it's important to plan early and to coordinate with your physician. So depending on the provinces you'll be in, some provinces require that the prescription or the medical order to actually receive an infusion needs to be done by a physician licensed in that province. So your care team can help navigate if that is the case, and help to navigate to ensure, you have orders and are able to sufficiently actually get drug in wherever you're traveling to. And then they may also be able to refer you to infusion clinics that can support your needs. It's important to do this early, though, because many infusion clinics, as I'm sure you all know better than I do, book way out in advance. So coordinating care and ensuring you can time your infusions properly with your travel will be important. When it comes to actually getting coverage for that treatment outside of your primary province. So typically for private insured patients, so people with private coverage, it's a little bit easier and should typically transfer automatically, but that there may be a case where you have to pay out of pocket and submit for reimbursement afterwards. When it comes to publicly reimbursed, it can be a little bit more challenging and is more common that you may face out-of-pocket costs that you have to then submit and get reimbursed back afterwards. But coordinating early with infusion clinics and care providers will help you because there is potential to get interprovincial billing. It just takes time and it can be a little bit of a complex process. So when booking with infusion clinics, that's a great time to reach out and ask them if they have any experience or can help you with any tips because they may be able to do that. And then, of course, your patient support program will be there to help you navigate this because they operate nationally.
Perfect. Thank you. So the next question is, what happens when you don't have access to a corporate drug plan? And I guess this is a Toronto specific question, but does Trillium benefit cover all or part of medication costs in Ontario? Our daughter will be out of age of a corporate benefit plan. So I added this question because I thought there's probably a lot of caregivers that are in this situation. So I thought it would be helpful for our individuals in our audience to have an answer or some.
Absolutely. So in the case of the Trillium benefit, it's Ontario. So depending on the age of the dependent, because aging out may happen at different times, they could be eligible for the OHIP Plus program if they're 24 or under. So that could be an option for them. But when it comes to Trillium specifically, so Trillium does cover all prescription drugs that are listed by the Ontario Drug Benefit Formulary, including those with limited use or special authorization criteria or exceptional access. So that would include the IBD drugs that we looked at on that big table. But it's important because Trillium only covers part of the medication costs. So there is an income-based deductible that is typically 4% of the net annual household income. So all of the income in a home, so parents' income as well as the dependents. So if this case, the daughter is working, even part-time, that all goes in. So 4% of that can be quite high. If it's a household income of $100,000, that's $4,000 that you're responsible for paying before Trillium coverage kicks in. So that's where those high income-based deductibles can be quite a barrier to access for patients. And then once Trillium kicks in, there's typically a copay associated with it, which is usually less than $10 per prescription.
Perfect. Thank you. The next question was, why are some biologics now being removed again?
So this question, I think, is likely related to biosimilar switch policies. So biosimilars will be introduced depending on when the original biologics patent lapses. So, and that will be different for every single one. Stelara, for example, we just saw biosimilars start to be introduced this year for that because the patent lapse, whereas things like Remicade, there's been biosimilars for years now. So that is why it may seem like biologics are being removed, and that's because those biosimilar switch policies are coming into play for drugs where new biosimilars are becoming available. It could also, depending on where they're located, for example, in Ontario being one of the last provinces to fully implement biosimilar switch policies, depending on that, they may be running into this now because provinces will give a transition period of typically 6 months, so patients can switch when those biosimilars become available.
Okay, thank you. That makes sense. I thought this was a timely question. Will the U.S. tariffs affect biologic sourcing and/or pricing?
Well, let me pull out my crystal ball and tell you maybe, but we can't predict the future. But what we do know is that currently Canada is not applying tariffs to pharmaceutical products that are imported from the US. So, but the pharmaceutical industry has a very global supply chain, and for biologics, many of their components are sourced from outside of the United States. So it could impact that. It could mean that they're, as we see companies change sourcing, there could be things that come up. But what we do know is happening is that these are being very closely monitored by wholesalers and distributors of medicines, as well as the pharmaceutical companies, to mitigate any of these challenges and mitigate the impact that it can have on patients. We learned a lot through the COVID-19 pandemic because there were a lot of supply challenges that happened with that. So as an industry, we learned a lot from that experience and are really applying that to be best prepared to avoid any impact onto patients as much as possible with this. So I can't give a clear answer. Who knows what's going to happen south of the border day after day? It could impact, but know that within Canada, we're doing as much as we can to help minimize the impact on patients in terms of not doing reciprocal tariffs from what's being imported from the US and preparing in terms of supply at the wholesaler level.
Okay. Good to know. Good to know. It's very reassuring.
Mm-hmm. And if you're on also know that for biologics, for Remicade, I think there's 6 biosimilars available. So there are, as much as each of them are unique and you'd have to coordinate with your care team, if there's supply issues, coordinating that early, there are options out there that exist. Mm-hmm. So hopefully that provides a little assurance as well, but I do know it is a very nuanced treatment algorithm for IBD patients with that.
Yeah, for sure. Okay, our next question is, what about moving to another country? Is it safe to do so for work if we are reliant on biologics and access to them?
So this really depends. Because of the word work included in there, I want to assume this individual would have private coverage, but just to cover it, if you did have public drug programs, you wouldn't have, that wouldn't continue if you move to a new country, because these public programs require you to be present in the province for a certain number of days a year. When it comes to private insurance, though, it's challenging to give a definitive answer because it depends. Likely your employer will provide a benefit package of some sort, but it will almost certainly be different than your existing drug plan. So as I mentioned, when talking about private plans, asking the details of it, asking for a benefits booklet so that you can evaluate if that plan would continue to cover your drugs. That's really important. And if it's your work that's, relocating you, coordinating with them, because there may be alternate solutions available so that your medical needs can continue to be met if you're moving to a new location there. So plan early and coordinate with your care team as well as your employer to get that information you need to evaluate whether or not it is safe for you to do so. It's also important to note there's a few things beyond just getting the drug covered. So depending on what country you're going to, is your drug even available? Is it even approved in that country? And then there may be costs that you experience beyond just the cost of the drug alone. So depending on where you are there fees that you have to face for infusion or certain medical appointments that are required for the administration of your drug that need to be considered? And is that covered in your benefits? So those are all factors to consider as a patient that may be looking to move to a new country.
Thank you. Okay, this question is, if we want to live abroad and the country doesn't have access to the same molecule as here, so touching upon what you just said, can the RAMQ pay for and send us the medication? We want to know what the procedures are for biologics.
No. As mentioned, the public plans require you to be located in the province. You have to live there. A RAMQ specifically, the drug has to be prescribed in Quebec. They have to be purchased and dispensed in Quebec, and the patient needs to be physically present to be eligible for RAMQ. So even to get it covered, and they most certainly won't ship the medicines to a different country.
The next question is, I do not have group insurance. I live in Nova Scotia, and I wonder if access to certain medications is easier in Quebec, as I'm considering moving there.
Yes, it typically is. And for several reasons. So Quebec, it has mandatory drug coverage. So if you don't have private insurance, you're automatically enrolled into the public plan, which is not the case in Nova Scotia. As we think back to that big table I showed, Quebec was the only province that had yes and green open benefit coverage for some of these advanced therapies. So there tends to be, broader access to the more advanced therapies in Quebec, especially compared to the rest of the provinces. Both provinces have income-based premiums, but typically in Quebec, patients face fewer barriers to access than they would in a province like Nova Scotia. So generally speaking, yes, access would be easier in a province like Quebec compared to Nova Scotia.
Okay, clear answer. Thank you. So this is also something that I saw, and I just picked one specific question, but it's changing meds and that being unable to afford it. So again, so the question is, my GI wants to change my meds to Skyrizi, and I can't afford it. No benefit coverage. What are my options?
So depending on your location, and there may be public insurance available to support you. But if there truly is no options that meet your needs, you fall in that underinsured population, coordinate with there's likely a patient support program. Skyrizi specifically has one. Speak to your patient support program, because there may be financial support through these programs to help patients navigate challenges like these.
Perfect. So I'll just do 2 more questions if that's okay.
Yeah.
We are at time. And then all the other questions, I will take them in. I will see if, Laura, if you're okay with it, I will share them with you and see if we can answer any. And I can get back with the participants after. Okay. Could you please discuss biologics or biosimilars recommended for seniors when Imuran no longer works for them, and if treatments are covered by the government? Maybe stick to the second half of this question.
Yeah. So I was going to say, I can't provide a recommendation on what treatment should be considered, but there are lots of options. There are lots of treatments indicated for IBD, and that's a discussion to have with your doctor. There is lots of coverage available for these through the government programs, but often we'll have, again, that special authorization criteria. So through discussions with your care team, you'll be able to determine, what treatment best suits your needs, your time point in your treatment journey. And there is generally coverage available through the government programs, especially for seniors.
Perfect. Oh, and that's, we can just wrap it up there. Perfect. So thank you so much, Laura and Paul, for for sharing your expertise with us today and answering all of these questions. It is, it's kind of a gray box, as they say, or black box. Actually, I'm not sure what the metaphor is, but, it's really helpful that we had you today to help us kind of, remove the mystery a little bit from drug reimbursement and access. So before we wrap up, I just want to do some housekeeping. So again, thank you so much to all of our everyone who registered today for our seminar and our webinar, and for joining us. If you have any other questions, please feel free to email us at learn@crohnsandcolitis.ca. And I will also be taking the questions that we received today and seeing if I can find answers to them and get back to you. You will also be receiving a quick survey at the end of this webinar. So please take 60 seconds to share your feedback. And it's really important for us to use this feedback to continue to develop the webinars. And next slide. I also wanted to say that we do have information on Crohn's and Colitis website. So I'm just sharing 2 QR codes here. So one we have on insurance and government support, and we also have another section on private insurance checklist. So what to look out for when you're trying to pick, or when you're changing a job and you need to try to understand which features are important for you as an individual living with IBD. So feel free to go through our website and learn about this aspect. And please feel free to also follow us on all our different social platforms. So on X, or it's Instagram, it's at Get Gutsy Canada. And before I close off, if I could just reiterate my thanks again to all the speakers today, to Gaishan and to Laura. Thank you so much for being so, for sharing your expertise, and then for sharing lived experience. Really appreciate everything you've come here today, and for an hour and a half shared all the insight you've gathered throughout this journey. So thank you again. And that's it for tonight, everyone. Thank you for joining. We'll see you at the next one. Good night, everyone.
Right. Thank you.
Bye.
Thank you so much.
Yeah, take care. Bye.